Very good afternoon to all. I am Dr. Luthra Mohan from the IP Digital Media team. We are here for the webinar on for the World Tuberculosis Day. Okay. So this webinar is being organized by IIP Women's Cell Tamil Nadu, Kanchipuram district. The speakers for today's session are Dr. Priyadarshini and Dr. S. Arvind. We are live on IIP India YouTube channel. So I request all to subscribe to this channel to get regular notification for webinars. Now we may start the webinar. I request the moderators to please take over.
Hi, ma'am. Thank you for that wonderful introduction. Hi, everyone. I'm Dr. Pradeepa, District Coordinator of Kanchipuram District. On this World Tuberculosis Day 2023, a webinar conducted to improve the awareness on tuberculosis through IAP platform and Tamil Nadu IAPWC, the Kanchipuram District have organized this current webinar. I would like to thank our mentors, Dr. Sanjeevja Sir, our IAP President, and Dr. Ruchivashni Ma'am, our IAP Treasurer and IAPWC National Head. And I would like to thank our Tamil Nadu State IAPWC Coordinator, Dr. V. Janani Ma'am, and Dr. Radha Balachandar Ma'am, our Joint Coordinator, to motivate us to conduct this webinar. Now we'll move on to the webinar. I would like to welcome our resource person, Dr. S. Priyadarshini, MBBS, MD, Community Medicine, to share her valuable knowledge towards tuberculosis under the topic TB epidemiology features and program. Ma'am has completed her MBBS from Vinayaka Mission Pondicherry University, MD, Community Medicine from Raja Mutaya Medical College and Research Institute. Dr. S. Priyadarshini started her career as Assistant Professor at Kalinga Institute of Medical Science, Bhubaneswar, Odisha in 2013 and later joined in Greater Chennai Corporation as Zonal Health Officer. Her current designation is Assistant Professor at Sri Ramachandra Medical College and Research Institute since 2016. She has experience in teaching for the past 5.5 years and administrative experience in rural and urban health centers for providing patients care, referral activities, organizing health camps, training medical and paramedical students, and research activities. Ma'am has given 2 publications, Coverage Survey of Measles Rubella Mass Vaccination Campaign in a Rural Area in Tamil Nadu 2019 for the Journal of Family Medical and Primary Care. Another publication for a long-term visual outcome following cataract surgery using intraocular lens, a community-based cross-sectional study in 2021. Ma'am has given a vast community and field experience. She was being a part of Pulse Polio program transition from bivalent OPV to trivalent OPV and birth and death registrations in zones 8, 9, and 11. Unwholesome food raids, sector activities, and conservancy inspections was done by her. And she has worked in the Chennai floods 2016 and handled various outbreaks in Zone 8. She has worked in activities of water analysis, shelter homes, slaughterhouses, and alcohol anonymous groups under Greater Chennai Corporation. Her other activities as a facilitator and resource faculty in basic epidemiology, statistics, and SPSS workshop conducted by the Department of Community Medicine of Sri Ramachandra Medical College and Research Institute, Porur, Chennai. She was a PG teacher for MD Community Medicine and other paramedical students. Her current designation as Assistant Professor in Ramachandra Medical College and Research Institute. We welcome you, ma'am. You can start with your presentation. Priya, ma'am?
Yes, ma'am. Yeah, thank you for the introduction. So before going to the webinar, at the outset, I would like to thank the Women's Association Physiotherapy, the committee members, the students of other universities, and Dr. Pratibha and Chandralekha and ma'am for giving me this opportunity to talk on TB on this day. So to the topic. So I've been given the topic, tuberculosis, epidemiology, management, and national program. So for the problem statement, before going to the topic proper, we look into the problem statement. So 1/3 of the global population are under asymptomatic infection, which means that they will have the infectious organism inside their body, but they'll not be producing any signs and symptoms. And usually it is acquired during the childhood. Among them, only 5 to 10% develop tuberculosis. So you know that 1/3 of the population will have the infection, but they'll not have any signs and symptoms. So only the 5 to 10% who come to our clinic will show signs and symptoms, and we recognize them as tuberculosis patients. So to the problem statement, every year we have 9 million incident cases, which means the new cases, which is going to be TB positive, proper positive cases. So if you look into the picture, you know that this is TB disease 9 million per year. So TB disease, in the sense, they have the infection as well as the signs and symptoms. And there is another term which is called the TB infection, wherein the patients will have the organism alone, but they'll not show any signs and symptoms. So these are the subclinical infection. So they will be going and giving more diseases to people, but they'll not be showing any infection per se. They'll not show any signs and symptoms. And that is the entire population. So this is how we are trying to detect the cases of the TB disease. So the other statistics, we have 56% of people in Asia accounting to TB, 29 from Africa, 1.3 million of HIV patients will be TB positive, and we have 20.5% previously treated multi-drug resistant TB, and 6% among them are children. So I have layered my slides in this way. The contents will be, first we'll look into the epidemiology, the clinical picture, diagnosis, treatment, prevention, control, and finally the program. So the basic facts about TB is that everyone knows it's an infectious disease, which means it transmits from one person to the another. It is caused by Mycobacterium tuberculosis, and mostly it affects the lungs. It affects the other sites. When it affects the other sites in the body, it's called extrapulmonary tuberculosis. Exactly, other than your hair and nail, it can affect anything and everything in your body. And it spreads through airborne infection. And the most common diagnosis is sputum smear microscopy. And it usually affects the economically productive age group. That is the working population. They go and they communicate with each other, and they have a chance of transmission as well. Now to the epidemiological triad. In community medicine, we call it epidemiological triad. Otherwise, you can just take it as etiology, the causative features. So the agent is Mycobacterium tuberculosis. It could be from a human source or from a bovine source, that is even from the animals. And the host is age. Usually it affects any age, but more so in the productive, as I showed you in the previous slide, it is the economically productive age group. Gender, it is more common in the males. So it is 2:1 ratio proportion for male is to female. And when there is a nutrition, malnutrition, or immunity is low, or there are more amount of risk factors like they are having HIV or any other disease, then they are more prone to get tuberculosis. Environment, as I said, it's an airborne infection. So the more closer you are, the more you're going to get the disease. So you can put anything into environment, overcrowding, large families, poor housing, whatever you can add when there is no space and you're going to share more of your aerosol infections across. The mode of transmission is airborne. There is a difference between aerosol infection and an airborne infection. In an aerosol infection, you sneeze out, you have the droplets, and it is there in the air, and after some time it may lie down. But in an airborne infection, the organism is so more that it is already in air and it becomes an airborne infection. So it is already there. So that means everyone is exposed to the disease per se. So let's look into the pathogenesis. So once, just presume that this is the bacilli. So first there will be bacilli, then we will have the macrophages, T lymphocytes, epithelial cells, which comes to rescue and get us away from the bacteria. And what happens? The giant cell forms. There will be necrosis, gone giant formation, and there'll be necrosis in the middle, and that will lead to fibrosis. So that is a simple pathology to understand how it will disrupt every cell inside your lung. So first we'll have a bacterial entry, and we have the fighter cells coming up, the T lymphocytes, macrophages, and epithelioid cells. And then there will be proliferation of the bacteria. You can see in every the circles, right? The cells, it is just proliferating. And then there will be central necrosis, which will lead to fibrosis. So now let's look into the clinical picture proper. So primary tuberculosis, as I said, it's going to be inside the lung, subpleural lung, and the accumulation is an act of neutrophils. 5 to 6 days, you will get a granuloma formation, and 2 to 8 weeks, it will get healed. That's called the Gone focus. The Gone focus plus some lymph node enlargement is called the Gone complex. Sometimes they may develop maturity, they become a subclinical case, and they can become Monto positive. Monto positive is a previous test which we were doing long back, a skin tuberculin test. And right now, since everyone is exposed to the organism, most probably everyone will be positive. But I already told you the difference between TB disease and TB infection. So we might fall into infection or disease. If you're in the disease, you will be positive and you'll be showing signs and symptoms as well. So let's see if we are not immunized. So if you are not immunized, you will either become a self-limiting disease, that is, we become TB infection, or we might develop into a primary complex. If it's going to progress and it's going to take overboard, then it will become a miliary TB or TB meningitis. And basically, we are giving the BCG vaccination for these 2 types of TB only. And it is more common in the malnourished children and also in the immunocompromised individuals, that is per se HIV. In secondary tuberculosis, that is, they have already been immunized, but there is some kind of reactivation or something reoccurs wherein you get the TB. That is like reactivation, and you may get a cavity, cessation of fibrosis. It could be pulmonary as well as it can be also extrapulmonary. And it can be in the local or a systemic spread or miliary. So it can go through the vein from the large ventricle to the whole body it can cause, or through the artery, miliary spread within the lung. There is another term called latent TB infection. That is, when the person breathes, the bacteria will get inside and it stays in the bottom of the lung. But the immune system will hold the bacteria. It will not allow it to multiply more. So he doesn't become infectious, and he will also not have any symptoms. But when the favorable conditions return, he can develop the disease. TB disease is where the same latent TB, it will be there, but the immune system cannot hold. The bacteria becomes to multiply and they will develop symptoms. So we have to know some epidemiological indices to quantify how the TB is going in the country. So to know that, you need to know a term which is called prevalence of infection, which is the percentage of individuals showing positive tuberculin tests. That is, those are all going to be positive for the bacteria which is inside the body. Incidence of infection, it is the new number of cases. You have a particular time, in this period of time, you're going to get cases positive. That is called incidence. Incidence is just the new number of cases, whereas prevalence is new and old cases together. You need to know the indices to quantify the disease. We also use these indices like prevalence of the disease, that is the number of TB cases at a given point in time. And incidence is the number of new as well as the recurrent episodes of TB. That is, they might have TB before, they must have been cured. So that time they'll be in the normal population. When they again get the disease, again they'll become a new case. So that will come under the incidence of the disease. So who is a pulmonary TB suspect? That is the clinical picture: cough for greater than 2 weeks, fever for greater than 2 weeks, hemoptysis, weight loss, and anything in the chest X-ray you pick up. If it's a pediatric TB suspect, the child will have persistent fever or cough for greater than 2 weeks, weight loss, and there is a history of any contact. Usually children, either in the childhood, they develop the Gone complex because of some contact in the house, maybe mother, father, or anyone in the house, they must have had the disease. We have drug-resistant TB suspect. This is, they have already undergone the treatment with first-line drugs, and they had either not taken the drugs properly, or they have stopped, or something must have happened. That becomes the drug-resistant. They're no more acting to the first-line drugs. So that's a failure treatment with first-line drugs. Pediatric TB non-responders, or drug-resistant, or with HIV co-infection, or they are in the first-line drugs, and after 3 weeks, when you take up the smear, again they'll show positive. They will not come up with a negative. Then we have to again finalize what it is, do a testing and find out which drug it is, and then which drug is resistant, and we go into the second-line drugs or previously treated TB cases. So I'm just focusing on pulmonary TB because it usually affects the lung more. So you might have symptoms like chest pain, coughing up blood, productive or prolonged cough, sometimes night sweats, and you feel appetite loss, fatigue, you will have drooping of shoulders. It usually shrinks you down. So this is how it usually attacks lung parenchyma, the first, then tracheobronchial tree. It could be miliary TB, as I already mentioned to you, via the artery and the vein. It can go through the entire body, or it can be the pulmonary TB, or along with extrapulmonary. Extrapulmonary means other than lung, anything it can affect. Now we'll go to the clinical picture of the extrapulmonary TB. The most common next to your lung will be TB lymphadenitis, which is seen in the cervical and supraclavicular area. And we can get a pleural TB, genitourinary, skeletal TB, meningitis, tuberculoma. So anything, it doesn't affect only your skin and your hair and nails, otherwise it can affect anything. So we're going to the control of tuberculosis. So we have two components in the control of tuberculosis. One is the curative component and one is the preventive component. In curative component, we basically go in case finding and detecting the cases, and the second part will be the treatment. In preventive component, even before the disease has occurred, we are trying to prevent it. So that is the BCG vaccination, and INH is isoniazid prophylaxis. We'll get to know the drugs in the future slides. So in case finding tools, we usually use the sputum microscopy and the famous Z-Nielsen staining and fluorescence microscopy. We have chest X-ray, then comes the sputum culture, usually the Lowenstein-Jensen stain. And we also have the rapid diagnostic molecular test, which is the CVNAT line probe assays. So usually just first two samples of sputum and a chest X-ray is enough to diagnose the case. If in case they are coming to drug resistant, now we are in a stage wherein we are going to multi-drug resistant and extremely drug resistant cases. We need all these assays to find out which genotype or which drug is resistant. So therein where comes your rapid diagnostic molecular tests. So some other your rapid diagnostic tests. So we have the genotype methods, wherein you're going to find the gene type of the bacteria which is inside the body, and the phenotypic methods are these, which will give you from your serum or blood, you can find which bacteria or which strain you have. We also have serological diagnosis of TB, like the Insta test TB, wherein it's an in vitro analysis, wherein you're going to take the your serum or the blood, any blood fluid, and we are going to find the antibody inside the solution, whatever specimen we get. Whereas in the genotypic, you're going to find the gene, which gene is for the microbe, and here you're going to find the antibody. So all these tests are given free of cost in the government scheme. So we'll go to the treatment of TB. So before we had like category 1, category 2, category 3, but now we just do according to the weight of the patient. So this is for an adult TB. So according to the weight, we are going to fixed FDC is called fixed dose combination. So depending on its tailor-made, usually the drugs are H, R, Z, E. H is isoniazid, R is rifampicin, Z is pyrazinamide, and E is ethambutol. Okay. So in the intensive phase is the first phase, continuation phase is the second phase. In the first phase, we give according to the weight like this, and for the continuation phase like this. And there is an injection streptomycin wherein it's given in grams depending on the weight. So the same thing we follow for the TB, for the pediatric TB, depending on the age. And just the ethambutol there, it is 275 universal, but here depending on the age, that also caters different. And again, injection streptomycin there, it is given in grams. Here, depending on the weight, we give it in milligrams. And if the body weight is more, then you will have to add an adult fixed dose combination as well. Like 25 to 29 kg, you can see 3 + 1A. That is, again, you're going to add one of the adult combination as well. So this is the fixed drug. According to your weight, it will be tailor-made and it will be given to you once you're diagnosed, once any patient is diagnosed TB positive. So the famous DOT strategy, this is what is followed all over now. And the plus point in this is that in the intensive phase, the patient will come all the 3 weeks to the supervisor or the observer, and he has to take the drug in front of the supervisor. This is basically to avoid the patients not taking the drugs properly. What happens in TB is that after 2 weeks, your symptoms come down and you start becoming okay. So the patients most of your relapse cases and failure cases occurs because of that. So to avoid that, DOT strategy has been very helpful. And then we have the continuation phase, wherein the patient, you know him already 3 weeks and he has been coming properly, and you know that. In the continuation phase, you have to only come for the first week, after which the other weeks they can come and get the drugs, but then they have to bring the strip which they had finished the drugs. to just ensure whether they have taken the drugs or not. So this is how the DOTS strategy works. We have the intensive phase and the continuation phase. So what do we do in the intensive phase is that basically we try killing all the organisms and try to cut down the resistance part. Whereas in the continuation phase, we try to eliminate all the relapses, failures, and persistence. So always it's intensive phase and the continuation phase. No more we follow category 1, 2, 3. At least that much you should know. And for the prevention of the disease, we have primary and secondary prevention. For the primary prevention, we have BCG vaccination and chemoprophylaxis. For the secondary prevention, it is early diagnosis and treatment. So BCG vaccination, like any other vaccination, it's going to give you the primary infection for artificial antibody for resistance, and it's given at birth, 0.05 ml, and it's an intradermal route. Dermis is something inside your skin. You don't give it IM, it's in the dermal area. So if you see in your left arm, you can see this. We have a bulb and we have a scar-like thing. For the uniformity, we put it on the left arm, and you can see in every child born, and it's the birthright, you can get it. Every child has the right to get the vaccination. Chemoprophylaxis, this is in cases where the child or anyone who has been exposed to anyone nearby the house or your roommates or your relatives with TB positive. And that time we give INH, which is isoniazid for 1 year, or isoniazid plus ethambutol for 9 months. So in chemotherapy, what happens is that we have just 2 types of drugs, as I already told you, HRZE. Either they are bactericidal or bacteriostatic. Bactericidal, as the name goes, cidal kills the bacilli. That is, we have rifampicin, streptomycin, and pyrazinamide. In bacteriostatic, it will halt the multiplication of the bacilli, thereby it doesn't put the immune system of the host very low. So we have the examples like ethambutol and thiacetone. So this is how the mechanism of the drugs plays in TB. So having finished that, we'll go to the national program. So we'll just roll through the program, like we'll just look into the burden, how the timeline, how the program evolved from time to time, now the NTB strategy, and then the goals and objectives prior, and now what we have the objectives, and what are the pillars they are actually standing right across now. So to look into the burden, in 2019, an estimated 10 million fell ill in the TB worldwide. And 1.4 million people died from TB. 8 countries account to 2/3 of the total, and India is the top leading. Anyway, the TB incidence is falling at about 2% per year. So this is your current status of the burden. So if you see the burden, the total number of new cases, I told you incidence means new cases. So TB incidence is 193 per 1 lakh population. HIV positive and TB new case will be 5.2. Multi-drug resistant is 9.1. So you see that rather than the new cases, the multi-drug resistant TBs are going more. That means the first-line drugs is not working. They are either they're not taking the drugs properly, they are relapsing it, or they're going in for a failure. So we are basically trying to stop that. And we have HIV negative TB mortality. That is, they're not HIV positive, but TB death is there. That is 32. And which is HIV positive as well as TB death. HIV positive, TB positive, and they go for death is 0.6. So just to be in a very easier way, we'll just look into this. The incidence is the kind of a greenish color, wherein it's coming down. I said, right, it's coming down to 2%. The new and the relapsed TB cases, see the notified, it's just going up. So new cases are going on. Whereas the HIV positive TB incidence is in the same, it's not picking up, it's not reverting down. Still, we have the incidence rate going down only 3%. SDGs, Sustainable Development Goals, we talk about it much nowadays. Before we were focusing on Millennium Development Goals, but now we come to the SDG. And according to that, we have to fulfill the goals by 2030. According to that, we have to progress more. 11% of incidence should be coming down to reach that goal. We'll look into SDG in the later slides. So let's see how the program evolved from time to time. So this is a very old program, 1962. It was first called the National TB Control Program, and they were just focusing on detecting cases and treatment. In 1992, WHO came down and evaluated the program. Now, why did they start and all those things? In 1993, it became the revised RNTCP, Revised National Tuberculosis Control Program. And that is when WHO even understood that it becomes a global emergency. It was declared global emergency. And we also coined the term DOTS, which is direct observed treatment short course chemotherapy, which I already explained to you why the patient comes to you and takes in front of you so that he doesn't miss any dose of a drug. And it comes in intensive and continuation phase. In 1997, they found DOTS was coming up better and patients were coming down. So they start to implement in a larger scale in a phased manner all through the country. In 1998, it was phase 1 of DARTS, and they were trying to cover up most of the districts and states inside the country. In 2006, it was phase 2, which was called the DOTS Plus. That is from 2006 to 2012. I'm sorry, there's a mistake, 2012. So what happens in DOTS Plus is that they found what should be tested. They were bringing more of, in the control program, we saw only diagnosis and treatment. So here in DOTS Plus, in DOTS, it was only the treatment and drugs. In DOTS Plus, they included the treatment, testing, surveillance, and also they were tailoring their drugs according to the weight, and they were mixing first and second line drugs, and they were going across that. In 2012, it is the phase 3, again with DOTS Plus from 2012 to 2017. And now we have the National Strategic Plan. We'll look into that in the future slides. And also in 2012, it became mandatory notification of TB. That is, if you see a case of TB, you know a case of TB, you have to come and notify to the government. And now it's all Nikshay. It's called Nikshay digital platform, wherein you're going to notify TB. And you have incentives if you notify for that. We'll look into that also in the future slides. In 2017, NSP was rolling through from 2017, and it has a deadline till 2025. Okay, that is NTB strategy and all that comes under the National Strategic Plan. In 2018, I've just put the recent updates. 13th March, we had TB Free India campaign. Some of you must have known it was campaigned by Narendra Modi ji. And in 25th September, we had that new kind of the icon for the program, TB Harega Desh Jeetegi. And in 2019 November, WHO came down and did a 2-week intensive review of how the program is going and how the cases are going across. And in 2020, it was declared, after 2019, they did a review and they declared in 1st Jan, the RNTCP2, the control program was converted into elimination program, National Tuberculosis Elimination Program. Under that, now we have the NSP, National Strategic Plan, which is running across from 2020 to 2025. So I presume that you will know how the program has been revolving from 1962 till date. So now we are coming to not controlling and all those things. We are from halting to control. We are coming to NTB strategy. And this is what I was talking about, the Sustainable Development Goals, which is 17 in number. And the third goal is more towards healthcare sector. And there are many, 3.1, 3.2, there are so many. In 3.3, we have the goal like NTB epidemic. Now, how are we going to do this? The vision is a world-free TB, and we are going to end the TB epidemic. Now, the SDG, what it says is that how are we going to end? We have the targets here. We have to reduce the number of TB deaths in 2030 by 90%, and in 2030 by 95%. The new cases incidence rate by 80%, and in 2035, 90%. And catastrophic, that is your poverty and cost-related effects, should come nil. That's how they propose to reduce the TB. Now, how are we are going to function all these things? So we look into the pillars. So they are trying to do with integrated patient-centered TB. So you're going to pull in all the departments and work across and focus more on prevention, bold policies and supportive systems, and research work as well. Now, the principles here, how are we going to do that? Is monitoring and evaluation. For any program or any disease to come down, you have to monitor, evaluate, surveillance. You keep on rechecking whether the cases are there and how it is going. That's how you can really reduce the case load. And we are going to pull in help from civil society communities. And the third principle is protecting human rights, because TB is a stigma. No one wants to come to the TB OPD and get the drugs, right? So you want to protect the human rights, ethics, and equity, as well as we are going in for a global collaboration, especially for the funding and adapting their strategies as well. So these are the previous goals, like from 1962 and all, directly to reduce the mortality, morbidity, and then to interrupt the chain of transmission. The objectives were to cure greater or equal to 85% of newly detected cases, and to detect greater than 70% of estimated new smear positive pulmonary TB cases. Now we have the revised objectives now to reduce the TB mortality, incidence of TB and mortality, and we are bringing in the emergence to prevent the emergence of drug resistance and effectively manage drug-resistant TB, to improve the outcomes among HIV-infected TB patients, to involve private sector, and to decentralize and align the RNTCP management with NHM block levels within the general health system. So in short, in the slide, what you have to know is more than just going into the incidence and mortality and everything, they started including the drug-resistant people, the HIV people, and they started pulling the private sector inside. And they also wanted decentralized, means giving it to the lowermost area where the field level work is happening. So they included all those in the objectives in the new program. So this is the program which we are right across now, the National Tuberculosis Elimination Program 2020 to 2025. The vision is 0 deaths and no poverty due to TB. And the goal is to achieve rapid decline in the burden of TB. And according to the SDG, I already showed you, the mortality should be 80% less in incidence and 90% less in deaths by 2025. So these are the impact indicators to reduce the TB incidence. In 2023, we have to reduce it by 77 per 1 lakh, TB prevalence by 90, mortality due to TB by 6, and the poverty and catastrophic cost by 0%. And the outcome indicators are listed below. So you can just have a look at that. So let's look into the objectives in a much simpler and understandable way. So basically, we are going to build everything. The base for how we are going to achieve all the targets, like strengthen and sustain the enabling policies, empower institutions, multi-sectoral collaborations, human resources, ecosystems, and everything. So we are going to build a very good base. And then we are going to prevent the cases which are missed out or vulnerable or highly risk groups. And then we are going to detect the cases wherever possible. And we are going to finally treat. So this is the new layout here. So we are going to first build, you can see in the base. So we are going to look into all these components and we are going to build a very stronger base, strength and sustain. And then we are going to prevent who are all left out, like in the latent TB infection. And we are going to scale up the measures at home, community and healthcare. Then we are going to detect using the intensified TB case finding efforts with the help of the Ministry of Family and Health Welfare and other ministries. And finally, we are going to treat even the multi-drug resistant TB strains. So from detect, treat, prevent, and build, which was first our understanding, now we have come up to a much more reformed form. Like first, let's build, prevent, detect, and treat. So the strategies are build, we'll prevent, detect, and treat. So we'll just look into how certain points, how to build up the strategies. So first was funding. So the global funding. So according to the US dollars, 280 million was there from April 2021 to March 2024. And we have the World Bank according to 50 million for the project. And then we have the USAID, the United Nations Office for Project Service, World Health Organization, and then obviously the Bill Gates and Melinda Foundation. So these are all funding for the TB. We have more also. I'm just giving you a brief view. And for the governance and management, we have the National TB Policy and TB Bill, which basically says, I told you about the principles, the rights, and their equity and all that comes under this bill. And there is a sub-national certification of disease-free status. This is basically, putting up all the, giving you an encouragement to come up with some disease-free status of the districts. So right now we have only one district in Jammu and Kashmir, which is free of the disease, and Union Territory, Lakshadweep, by 24th March 2021. And we have a gazette on TB notification. That is, if you don't notify anyone you know of TB case, or you come across or you're diagnosed in a clinic, it is a offense and they charge you in the penal code. And the most important in governance and management is direct benefit transfer schemes. That is, if you're going to do anything relating to these schemes, you will be given funds. So we'll just look into what are the schemes under the direct benefit transfer schemes. One is Nikshay Poshan Yojana. So this is basically the Nikshay thing wherein you're going to activate, or you're going to say who is affected by TB, and you'll get an incentive of 500 rupees. Treatment supporter is basically the DOTS provider. They do a lot of work. So therein the incentive goes from 1,000 to 3,000 rupees. For a private provider, you are going and you're yourself admitting that you had TB, or you're telling someone has TB, then it's also again 500 rupees. For the tribal patient support from there, it is 750 rupees. So these are the beneficiaries who have got. So totally they have done cross in 2020. And to avoid duplication and any misstep of the funds transferring, we also have the digital signature certificate, wherein it will directly get into your banks. Okay, so 82% of the districts have already implemented the digital signature certificate. So you're going to notify in the direct benefit schemes, it will directly get transferred and the incentives will get transferred for you. So basically the government is doing the dog and the bone show. They are giving money and they're asking people to come and get the treatment. So how does this work? So this is the organogram. So we have the national level, the state level TB center, district level TB center, TB unit, diagnostic center, and finally the dots. So herein you get diagnosed, you go under your diagnostic features, and finally you get your drugs there. So we have the boards as well from the national level, state level, district level, and your block level. So this is how the skeletal structure is there, and every state and district functions like this. Now we can't just do with the governments and engagement and just funding. So we have to look into the private sector engagement also. So that is one is the DBT, direct funds transfer, and then joint effort elimination of TB. These are just private institutions like the Health Research Innovation or the Clinda Foundation or New Diagnostic Foundation. They also do the screening outreach functions, and they will also give a hand in reducing the TB. So their theme is basically go where the patients go behind them and get them and ask them to take the drugs and be in a complete follow-up. So what do? Is free diagnostic test, collection, transportation, free drugs, and then socioeconomic support through linkages and partnerships, free treatment, all this what they do. So this is all purely private, but they're giving hand in hand with the government to reduce the mortality and morbidity. And we also have the corporate TB pledge, which will also help in the outcomes of the TB. So if you're in a corporate setup like an Apollo or any other bigger corporate setup, you can take the pledge, and depending on what work you do for reducing the TB, you will be awarded this certificate, either a silver member, gold member, platinum member, or diamond member. So if you're a silver, you're just committing that you will reduce the TB, and you can create awareness, you get a gold. You also do an investment in that, you are given a platinum membership, and you can become a champion. That is, you can post awareness programs and do things and lead across states, and that you will become a TB champion as well. So government is basically enthusiastically motivating people to come across so that it will affect the outcomes of the TB health. So this is what the Apollo Tires did, and they had done a 2-week campaign in 31 different locations in 19 states. And they had put 52 TB patients identified, and they had put on treatment. So they had detected and put on treatment. And you can get a certificate like this, which is an honor. And the other than private, they are also private sector. The next point is to engage and empower communities. So you can, you can see the block level officer talking, and he's creating awareness to come and join forth to reduce the TB mortality and morbidity. And here you have a survivor who is talking in Chhattisgarh to the other patients to come motivate and get treated and tested. So this is TB Champions, as I already told you. So you have many programs like Touch by TB. You can start your own program, and you can, it's led, and you become an example for the other people to join hands for bringing down the TB. So this is the TB Elimination Jharkhand, TEJ. So these are some of the examples. There are many more, right? And nothing comes without advocacy and communications. So we were rebranding the RNTCP. So this is the new logo we have here. And the red color, I hope you've all seen, this is the National Tuberculosis Elimination Program symbol. So the red color is the beginning, emotions and energy, everything. The red color is something very good. Yellow is protection. TB Mukt Bharat is something, TB Free Bharat. And the swirl of the flag is pride of all, and focus on the program because most of it is focused on the lungs. And celebration positivity, the human figure is for celebration positivity and success. And this is for the greater picture, the entire population per se. So, and then not but last the least, surveillance, monitoring and supervision. This is the key role for any program, as I already told you. So only after we had that 2-week epidemiology, 2-week WHO survey did they announce that we became from RNTCP to RNEP elimination program. So we have the National TB Prevalence Survey, which was happening 25th September 2019, and it keeps on going. And there is a state TB index. We have notification. We have BRICS countries like Brazil, India, Russia, China, and South Africa research team, and they do and keep surveillance and monitoring. That's basically you keep a check of the cases and what is happening in the field level to know whether the cases have come down or not. So this is the Nixchai. We'll be finally into this platform in the forthcoming years. Everything will be in your Android phone. You can, your dots, your diagnosis, everything will be loaded inside the phone. So we already have a framework how the Nixtray platform works. We have the surveillance, supervision, monitoring, and evaluation system. We have the TB intelligence, knowledge session, training, and the Samarth. So this is how it functions. And this is the full-fledged Nixtray platform will be like this, wherein it will be stored in the cloud, and you will have it over your email, SMS, everything is going to be digital. So we can easily keep a track of all the cases. You're going to get the statistics, all the vitals, everything linked to your Aadhaar and everything, and it comes then and there. So if I don't mention about COVID, it will not be full. So what happened to TB? We were actually going back last 5 years when we had the TB attack. So the number of cases and the deaths increased because of COVID. And you can see in this graph that in 2019, you can see it's not peeping down, it's at least in a same line. Whereas in 2020, it is coming down, and again, it's picking up. So the notifications became less. So it became much more not concerned because we were more focusing on the COVID. So we were accounting for more deaths and cases during the COVID era. So you can see these registrations as well. In 2020, if you see the darker, thicker lines, the registrations are coming down so low. And the dots completion is also not much appreciated. So that is about the build. How are we building the base for the TB? Now we'll go into how to prevent. So these categories are those which will come into prevent TB category. That is the latent TB. They have the infection, but they will not produce any symptoms or disease. Household contact, you have contacted someone, patient living with HIV, pediatric contact, immunosuppressive therapy, dialysis patients, transplanted patients. All these people are more vulnerable for TB. So we will try to prevent all these patients. And airborne infection control, as I told you already, it's an airborne infection. So the government gives you the airborne kit is there. In the kit, you have some 5 disposable multi-layered masks, and you have spitones and phenol solution. Basically, that is to spit your sputum, and you basically bring down the airborne infection under control. These are some of the strategies to prevent TB. And next is the case finding. How do we detect it? Way back in 1962, it was in the health facility. You come to the clinic and you find out. Then in 2001, we revised ourselves and we were trying to find out with the comorbid conditions like HIV and diabetes mellitus. After that, it was the active case finding, the systemic vulnerable screening populations and population-based screening in 2020, vulnerability mapping periodic, more of screening was done. So everything is, again, the case detection now, we have to turn it to Nixtray. We have to go and notify there, and the patient will be given, notified TB patient will give 750 rupees at the time of, as an incentive. So this is the joint TB collaboration. So the program for the non-communicable diseases, we also have a link, and you can also collect bidirectional screening. You can get yourself screened for diabetes as well as TB, and you can also get the treatment drugs. So this is with the AIDS program. Here also you have bidirectional drug-resistant TB, and you have single window services for TB and HIV. Okay, so you can get the ART drugs as well as the drug-resistant TB services in all medical colleges. And TB and tobacco is also combined together. And the childhood TB. So this is RBSK is Rashtriya Bal is small children, Swasthya Karyakram, and Rashtriya Kishore is adolescents. So among these children also, 0 to 18 groups also, it has been screened in that program as well. 2-way window we have for every program. So it is linked to all the programs so that we can pick up patients there also. Case finding basically. Now, how do we treat TB? We have separate regimens for drug sensitive, for mono and poly drug resistant TB, multi-drug resistant TB, and extremely drug resistant TB. Now, what are we doing in the National Strategic Plan? Rather than just mere microscopy, we have gone into the NAT and genome sequencing and finally directly finding what sequence, what drug, and directly give it to it. That is the more advanced way of treating the TB cases here. And what is the pillar or the principles behind? We want to get out of the injectable form so that it stays within our first and second line drugs. We are not going into multi-drug resistant varieties. So rule out the injectable form. And we have to follow up a case even if it is negative for 2 years to see that it does not relapse out back. And then digital adherence so that everything is, you get in time to time and everything is stored. You really don't have to do paperwork and then get the statistics and then file it up. It's nothing like that. And everything is see-through. So these are the 3 treatment pillars we are going to follow in National Strategic Plan till 2025. So we have the algorithms for all the different cases, as I told you, whether drug resistant or whatever. It's a very simple algorithm. If it's smear positive, if it is X-ray positive, you just have to strictly follow this, just that you have to strictly follow the algorithm. And for every TB cases, we have to offer HIV counseling. That is a must. So this is, you can just go through. It's very easy, understandable. You can just read through. It is available in all the WHO sites. This is for the children. This is for TB children. And we also, this is the daily dose regimen for drug sensitive TB. So it's intensive phase, focused, fixed drug combinations for 2 months. And for continuation phase, it's for 6 months. And we have it for the children as well, drug sensitive TB. These are the drugs we use for long-term multi-drug resistant drug resistant TB. And usually Bedaquiline is the hero here. We use this drug mostly. You have group A, group B, and group C. These are the drugs. We basically, what we are focusing is not to go into these drugs and just limit to the HRZT group and finish the regimen. And we also have a separate algorithm for pregnancy. So in pregnancy, usually if it is less than 20 weeks, we always advise MTP. That is nothing but abortion. Medical termination of pregnancy, 1971 Act. So you can do that. Otherwise, if it's more than 20 weeks, we have the algorithm, as I already said, you can go through this. So these are my references, if you're interested to go across and read. And thank you. This is the picture of the National Institute of Research in Tuberculosis in Chennai. It's way old in Cheppat, 1969. So you can pay a visit to know what happens in Tamil Nadu TB units and centers. Thank you. Thank you for your time.
Thank you, ma'am. Thank you for a wonderful presentation. You have closed your sharing link.
Yes.
Yes. Thank you, ma'am, for this wonderful presentation. I would like to call upon Dr. Chandralekha, ma'am,
Yes,
the
ma'am.
subcoordinator of Tamil Nadu IEPWC, Kanchipuram district, to invite Dr. Arvind sir to the webinar. I would like to thank Dr. Sendil Selvam sir of Vistas, Dean of Vistas, for making sir's presentation on this webinar. Thank you, sir. Chandralekha, ma'am?
Yes, ma'am.
Yeah, you can proceed, ma'am.
Yes, ma'am. Thank you, Pradeepa, ma'am. Good afternoon, everyone. It's my pleasure to be a part of member in IAPWBC. My sincere thanks to all my mentors. I would like to invite our resource person, Dr. Aravind, MPT Cardio Science. Dr. Arvind sir, in lifetime member of Indian Association of Physiotherapy, Chennai. Dr. Arvind completed Bachelor of Physiotherapy at Mada College of Physiotherapy, and sir has finished his MPT Cardiopulmonary Science at Sri Ramachandra University, Porur, Chennai. Dr. Arvind has completed Master in Psychology at Tamil Nadu Open University, Chennai, and sir pursuing his PhD in Physiotherapy at School of Physiotherapy, Wales, Institute of Science, Technology and Advanced Studies, Vistas, Colombo. Dr. Arvind has been own clinic practice since 2012, have worked as a ICU physiotherapist, cardiothoracic unit at Miyat International Hospital, Manapakkam, and he has worked as an assistant professor at Jaya College of Physiotherapy, Chennai, and ACS College of Physiotherapy and Mada College of Physiotherapy. And sir is currently working as an assistant professor at Vistas. Dr. Arvind has organized and presented more than 10 seminars, workshops, and many free physiotherapy camps. The sir going to be a topic to be presented by today, the role of physiotherapy in the management of pulmonary TB. Sir, I'm welcoming you. So over to you, sir.
Thank you, ma'am.
Arvind sir.
Thank you, ma'am. Thanks a lot, ma'am. So greetings to one and all present here. I would like to thank the IAP team, the Tamil Nadu IAP Women's Cell, for providing me this wonderful opportunity. And I would also like to thank our beloved HOD sir, Dr. Sendil Selvam sir, who is a great motivation behind me. And I also heartiest welcome to the participants. So let us start with the session now. I'm sharing my screen. So for the next 20 to 30 minutes, I'll be talking about the role of physiotherapy in the management of pulmonary tuberculosis. And to be precise, I'll be talking about the pulmonary rehabilitation from the physiotherapist perspective. Just very superficially, I'm not going to give any deeper insights in this, considering the time constraints. Let us have a look at the role of physiotherapy in the management of pulmonary TB. So Dr. Priya ma'am has beautifully explained the clinical aspects of the tuberculosis. So as we all know, tuberculosis it is until now, it is a leading cause of morbidity and mortality worldwide. And it is a bacterial infection basically, and it is a systemic disorder. Means it involves it is a multi-system disease. But here we are concerned, we are much more bothered about the pulmonary component alone. So the impact of tuberculosis on the patient's life is highly significant, and it affects the physical, mental, and social domains of the patient. It deconditions the patient, and not only the active phase, but also in the post-TB sequel also. So although with specific anti-tuberculosis treatment, although the drug therapies are available, even though the sputum negativity can be achieved, means the patient can get rid of the bacterium, but still the extrapulmonary symptoms like the cachexia or muscular weakness, depression, they persist for a longer time. So physiotherapy, which is actually a part of the pulmonary rehabilitation, may be very useful in aiding the recovery in both the active and the sequel phase of the tuberculosis. So the pulmonary rehabilitation. So actually the pulmonary rehabilitation is a multidisciplinary program, multidisciplinary in the sense. So it involves specialists or professionals from other domains also. And we actually aim the people who are having respiratory impairments, respiratory disorders, with the clinical and functional status impairments also. And these things would have consequences on a long-term basis on their daily life activities and their quality of life. So the pulmonary rehabilitation programs, they try to improve the symptoms. They try to alleviate the symptom, and they improve the exercise capacity and also the social integration. Okay, so let us divide this into two, like rehab in the active phase of TB and rehab in the post-TB sequel. So in the active phase of TB, so it is actually an intense chronic inflammatory syndrome, which is going to which results in release of many cytokines and the TNF and interleukins, etc. And due to this, the patient would have they might have weight loss, asthenia, and exercise dyspnea. So the main indication, so why these people are included in rehabilitation is like because they are having high degree of physical and mental deconditioning. So the aim is to reach the maximum level of physical independence, means to improve their physical the functional status, and community reintegration after the hospital discharge. So in active phase, so what we do as physiotherapists, actually, they usually advise like the patient should take bed rest and to avoid physical stress, like a patient should avoid exercises and all. But still, it is not always true. Like it is now recently it is being evident that physical activity, like minimal physical activity, can be very much beneficial for the patient in terms of the improving their functional status. So high intensity intense exercises, high intensity exercises can be avoided in people whose clinical condition is very unstable, like whose the TB, if the TB manifestation is very severe, the intense exercise can be avoided. But in case of the TB people, the patients who have a normal course, like a stable course of the disease, exercise can be recommended. So this is a very earlier study, like it dates back to 1960s actually. The purpose of mentioning such an earlier study is like to indicate the importance of exercises. So very long ago, they have shown, like they have proven that earlier initiation of a complex pulmonary rehabilitation program may allow a social and work reintegration of the patients with TB after a hospital discharge. So this shows the importance of rehabilitation program. So usually what we do in the active TB phase initially, we can prescribe some very minimal intensity exercise, very light exercise in first few days, because the patients would be totally physically deconditioned. They might have cachexia, they might have asthenia and all. So we can prescribe very minimal exercises, and to start with, we shall also do passive exercises, because if they are very much deconditioned, passive exercises can be helpful, and it can be progressed gradually. Passive exercises which can be followed by active assisted, and once the condition improves, active exercises can be taught. Active free exercises can be taught to the patient. And while prescribing exercises or while giving exercises, we should take the patient's condition into consideration, so that a tailored, patient-centered program can be designed. Okay, so exercises at a slow pace. So initially, we should give exercises at a very slow pace, normal pace, and then we can slowly, gradually increase the pace of the exercises based upon the degree of precision and the postural control. So we shall also progress, like we can give minimal resistance training also, like which might help in muscle strength. And so while prescribing progressive resistance training, we shall slowly, gradually increase the repetitions, or we can increase the resistance. And so this might help. So initially free exercises can help. And once the patient is stable and if he is able to tolerate the exercises, we shall move to the progressive resistance training, and to start with very minimal resistance and minimal repetitions. So these exercises would target both the upper limb and the lower limbs. So once the patient is very much stable, so we can perform some exercise testing, like 6-minute walk test can be done. And so it can be used as a outcome parameter. So we can also, so once we do the test, we shall analyze the stability, the stamina level of the patient. Then we shall give them like stationary cycling, or means any sort of aerobic exercises or resistance training, and we can give. And we shall again re-perform the walk test, re-perform the stress testing, and we shall compare it with the previous one. So we shall know whether the exercises are responding. We shall analyze the prognosis of the patient also. So the intensity of the exercises can be progressively increased. So based upon the patient's tolerance, we can progressively increase the intensity of the exercises. So in addition to the exercises, we shall also give some relaxation techniques or postural correction and breathing training and all. We shall give, for example, diaphragmatic breathing, the belly breathing technique, which we use to induce relaxation and to improve the oxygenation. So this is in the active phase. So now let us move to the pulmonary rehabilitation in the post-tuberculosis sequel. So the thing is, like there is a lack of studies. There are not much of studies which are supporting the pulmonary rehabilitation in the post-TB sequel, unlike in COPD. And usually medically, the patients would be prescribed with bronchodilators, inhaled corticosteroids, O2 therapy and all. But even though there are few studies available, but still these studies strongly support that pulmonary rehabilitation in post-TB sequel has positive results in exercise tolerance and in alleviating symptoms and improving the quality of life. So the aim is like to alleviate the symptoms which are related to the bronchiectasis, but in the bronchiectasis has been caused because of TB, like because of the tuberculosis, the supporting structures of the bronchial the bronchial wall has been damaged and resulting in permanent dilatation of the bronchus. So these symptoms can be alleviated using pulmonary rehabilitation protocols, and also to improve the and also to correct the muscular weakness, which can lead to functional impairment or dyspnea and all. So when the TB heals with the sequel bronchiectasis, the patient might have bronchoria or respiratory infections and hemoptysis and etc., which might affect the quality of life of the patient in a very significant manner. So in these cases, we shall provide any airway clearance techniques for the patient, like for example, postural drainage or autogenic drainage. These are all the airway clearance techniques. So postural drainage, as we all know, this is a treatment technique, airway clearance technique, where we are going to prescribe some postures, gravity assisted postures, where they are highly helpful in removing the secretions. And autogenic drainage is a self drainage method, where we teach the patient to it aims at three things, like the main objective is to remove the sputum mobilize the sputum from the peripheral airways and to move it centrally. And it is done based upon, it is done in three phases, like unsticking, collecting and evacuating phase. And we usually prescribe some breathing techniques in different lung volumes, low and middle and high lung volumes. And we also teach the patient some forceful expiratory techniques like huffing or coughing, so that the sputum is removed very efficiently. And another technique is ACBT, active cycle of breathing technique. It is actually a simple breathing technique which is used to clear lung secretions, and it also improves cough efficiency and ventilation. So in active cycle of breathing technique, we have certain components like deep breathing exercises and thoracic expansion exercises and coughing, the forced expiratory techniques. And cough education can be given. Cough techniques can also be taught to the patient. So, and there are various studies which have proven that aerobic training is very much beneficial. So particularly for like 3 sessions per week, at least to 6 to 8 weeks, the aerobic training can be given in the form of either treadmill or cycle ergometer, and any form of aerobic training can be given, and they are effective in improving the physical tolerance and quality of life. And apart from these, exercises to enhance the lung and thoracic expansion, like breathing exercises, diaphragmatic breathing or segmental breathing exercises, these can be prescribed, and which might improve the lung and thoracic expansion, and obviously ventilation and oxygenation can be improved. So to conclude with, like there are really few studies in scientific literature pertaining to the effects of rehab program in TB. There are no proper supportive articles, but still the available evidences are strongly suggestive of pulmonary rehabilitation in TB patients. So they show that these the protocols might improve the patients in symptom wise, and they might improve the exercise tolerance, and they improve the quality of life also. So the indications are like patients who have symptoms, and patients having lung destruction and reduced pulmonary function, muscle weakness, and decreased exercise tolerance and impaired quality of life. These people can be included in the rehabilitation program, and still further studies with larger number of patients and control groups are needed. So to conclude with, the main role of pulmonary rehabilitation seems to be like in the management of post-TB sequelae. But again, there is a positive feedback about the benefits of using rehabilitation from the active phase of disease itself. So thank you so much.
Thank you, sir. Participants, you have any questions, can ask.
Participants, both our resource persons, Dr. Priyadarshini and Dr. Arvind sir, is online, so you can proceed with your questions if you have any. No questions. I would like and request our participants to share your mail IDs and your name to the mobile number mentioned in the chat box to receive your e-certificates. Chandralekha ma'am, shall we proceed? Thank you, Sam. Thank you, Prabhakar sir. Any other questions? If once the treatment is completed, is there any possibility of reoccurrence? So there's a question for you, Arvind sir. If
Yes,
once the treatment is completed, is there any possibility of reoccurrence?
provided if they didn't take the DOS therapy properly, there are chances of reoccurrences.
Participants, any other questions? Yes. I would like to thank Indian Association of Physiotherapy and Indian Association of Physiotherapy Women's Cell and Tamil Nadu IAPWC for giving us this valuable opportunity to conduct this webinar on this World Tuberculosis Day 2023. I would like to thank our mentors, Dr. Sanjeev K. Jha sir, our IAP president, and Dr. Ruchivashni ma'am, our IAP treasurer and IAPWC national head, and our Tamil Nadu state IAPWC coordinator, Dr. V. Janani ma'am, and Dr. Radha Balachandar ma'am, our Tamil Nadu State Joint Coordinator, IAPWC, to make this happen. I would like to call upon, I would like to thank both resource persons who gave their valuable and responsible presentation over this webinar. Thank you, Dr. Priyadarshini ma'am and Dr. Arvind sir. Thank you all.
Thank you, ma'am. Thank you so much.
Thank you once again to all the participants, and thank you. Special thanks to our Vistas HOD, Senthil Selvam sir, to participate in this webinar. Thank you all students and professionals for participating in this webinar, and in future, Kanchipuram District IAPWC will be conducting more webinars which will be more informative for you all. Thank you once again. Thank you.